theories on state healthcare affordability initiatives. As we all know, the cost of prescription drugs in the United States has been a growing concern for many years, and it's one of the most pressing issues facing healthcare today. Prescription medications are essential for curing, treating, and managing various health conditions, but their high health prices place a significant financial burden on individuals and families. Just last year, a KFF study found that 28% of adults reported difficulty affording their prescription drugs, and 3 in 10 reported not taking their medication as prescribed due to cost. Recently, public attention has focused on federal action to address prescription drug affordability. Notably, the Inflation Reduction Act's provisions to allow Medicare to negotiate prices for certain high-cost drugs, the Medicare Part D $2,000 out-of-pocket cost cap, as well as the $35 monthly insulin copayment cap. However, there have been several innovative state-level initiatives to lower pharmaceutical costs and improve both affordability and access. Today, we are fortunate to have 3 expert policymakers with us. Each will be bringing valuable perspectives and insights into how state-level initiatives can alleviate the financial burden on consumers and help ensure that everyone has access to the prescription medications and treatments that they need. Over the next hour, we will be hearing from Dr. Andrew York, who is the Executive Director of the Maryland Prescription Drug Affordability Board, Shabnam Salih, Director of the New Jersey Governor's Office of Healthcare Affordability and Transparency, and Dr. Beth Slamowitz, Senior Policy Advisor on Pharmacy at the Nevada Department of Health and Human Services. But before we get started, I wanted to walk through a few virtual housekeeping items. Today's session is being recorded, and the recording as well as an event recap will be available on the CAP website shortly. And to ensure that today's event is accessible, closed captioning is available. You can activate this feature by clicking on the closed captioning button at the bottom of your Zoom screen. Finally, we encourage you to use the Q&A feature to submit your questions. We hope to get to as many of them as possible this afternoon. So with that being said, I am going to go ahead and turn the virtual mic over to Andy York so that we can walk through his presentation. Andy?
Thanks, Natasha. And presentation is up. Great. So thank you so much for the opportunity to talk to everyone today. My name is Andy York, and I am the Executive Director of the, oops, is my video showing? There we go. Can you see me now? Sorry about that. My name is Andy York, and I'm the Executive Director of the Maryland Prescription Drug Affordability Board. And today I was just going to talk a little bit about what these boards are and what they do. I'll spend most of the time talking about something called the cost review study process. They have slightly different names for each of the boards, but that's because that is a common feature across the boards, but I'll also talk about some of the differences between the boards as well. Next slide, please. So again, just going to give an overview of the affordability boards themselves, and then also try to do a little bit of a deeper dive on the cost review study process, which is a unifying feature across the boards. Next slide. So the Maryland Prescription Drug Affordability Board was the first created affordability board. We were created in 2019, and we are a small independent agency dedicated to making prescription drugs more affordable for Maryland residents. It is a 5-member board, and we have a 26-member stakeholder council. This is an advisory body that provides subject matter expertise from different representatives throughout the supply chain. And the purpose of the board is to protect state residents, state and local governments, commercial plans, healthcare providers, pharmacies licensed in the state, and other stakeholders within the healthcare system from the high cost of prescription drug products. And I do like to take that language straight from our legislation because it does kind of guide the purpose and the work of the board. There's about probably 4 to 5 other boards that are out there, and all of them seem to be based on the same kind of general model of legislation, but there are some differences with the boards. All of them are boards. All of them seem to have a stakeholder or kind of advisory council, but they have slightly different authorities in what each of these boards can do. Next slide. In terms of the Maryland Prescription Drug Affordability Board, we have kind of three things that we spend most of our time and resources doing. The first one is within our statute and legislation. That's these cost reviews. It's called the cost review study process in Maryland. I think in Colorado, it's called an affordability review. But most of these entities have some sort of kind of investigative authority or research authority to understand the drivers of what may cause affordability challenges for prescription drugs. And I'll go into depth on that in just a moment. Next is a novel policy that's available to some of the prescription drug affordability boards. In Maryland, we have upper payment limits authority for state and local government. And then other states, Colorado immediately comes to mind, but I believe Washington and potentially Minnesota as well, can set the upper payment limits across the entire state. And basically, upper payment limits are a novel policy tool to try to make prescription drugs more affordable. It's kind of up to each of these boards to figure out, how to implement this tool. And in Maryland, we have to do something called our upper payment limit action plan, which basically describes how you would implement the upper payment limit. That would then go to our General Assembly for approval, and then we would be able to implement after that. So happy to provide some information on that, but in the Q&A, but otherwise, just wanted to reference that is a tool that a lot of these boards can potentially have. And then finally, we can also recommend additional policies. So I think all boards, including Maryland, have kind of annual reports that they do. And one of the things they are meant to do is almost be kind of subject matter experts in prescription drug pricing and affordability that's available to other partners within the state, whether that be the legislator or other parts of the executive branch. As Natasha mentioned, this continues to be a high priority target for a lot of our policymakers. So we hope to be a resource for those entities that are working through these issues. Next slide. So the cost review study process is basically the bread and butter of our work. And it basically allows us to understand if and how a prescription drug is causing affordability challenges. Ultimately, what we see, even as a policymaker, and I think a lot of the folks listening in on this probably can relate to this, but first, the prescription drug market is an extremely complex system where, the publicly available prices often don't reflect what's the actual net prices are. And then also just a number of different entities within the supply chain all kind of have their own interesting incentives. So what we see at the policy level is kind of the gross paid amount that goes from the payer to the pharmacy. And we don't really see much more beyond that. Some states have transparency programs that might capture some transactions within the supply chain. But ultimately, we often usually do work on something called like a all payer claims database, which is reported from payers within the state to the state. And that's where a lot of this comes from. And that is kind of the gross spend. It's not the net spend. And if anyone has any experience in this space, we know that kind of rebates can be a major kind of driver of what the actual net spend of the drug is. So ultimately, the purpose of this cost review process is for us to better understand if a drug is causing an affordability challenge for patients or the state. The statute laid out the drugs that are eligible for these cost review studies. Often they're very high cost drugs. So brand name drugs with WAC of over $30,000 per year, name brand drugs that increase by $3,000 over a year, or biosimilars that come to market and are at least 15% less than the reference biologic. And then also generic drugs that are more than $100 per month and go up over 200% in 1 year. And then also in Maryland, this might be unique to Maryland, is the ability to add additional metrics. And our board did add additional metrics to our regulations to try to identify drugs that should be high priority drugs that don't meet these specific criteria. Just a couple examples are kind of the highest overall spend in the state. So just kind of looking at the gross spend on the drug. Drugs with the highest out-of-pocket cost per patient, total out-of-pocket cost, and then also per patient out-of-pocket cost. So they've added those to make those drugs eligible as well. Next slide. So again, the purpose is to basically allow the board to do an in-depth analysis based on available and collected data. And ultimately what the board is trying to determine, and the definition is slightly different for each statute, but in Maryland, the board is trying to determine whether the use of the prescription drug that is fully consistent with the indication is approved by the United States Food and Drug Administration or standard medical practice has led or will lead to affordability challenges for the state healthcare system or high out-of-pocket costs. So that's ultimately what the outcome of this process should look like. Next slide. So we created our cost review study process. We published it in regulations. Both you can go to these regulations on our website if you want to see the process. And we've been going through this process starting, I believe in March of this year, we really kicked this process off. Next slide. And basically there's kind of 5 key steps. There's the identifying the drugs that are eligible. Then the board selects drugs for the cost review study process. Then we collect the information and data necessary to do the cost review study. Then we analyze the data, and then the board will present their results. Next slide. So we created a process where basically in an initial meeting, so the board gets a dashboard of probably about 1,100 eligible drugs. And that's a board-facing dashboard. And then what they do is they select drugs that they want more information on from that larger list. So they come up with a subset of drugs that they want more information on. And what they do is they refer that to their stakeholder council. And we also seek public comment. So I believe that happened in March. They selected 8 drugs they referred 8 drugs to the stakeholder council and received public comment on that. Then in a subsequent meeting, they have to consider all the information that they received in that process, and then they get to select drugs for the cost review study process. So on May 20th, our board selected 6 drugs for the cost review study process. So we are now actively going through the cost review study process right now. So shortly, we'll be doing something called our request for information, where we're going to request and collect information to allow us to answer a lot of the study questions in the cost review study process. And then ultimately, the board is going to make a determination of whether or not the drug has led or will lead to affordability challenges for the state healthcare system or a high out-of-pocket cost for patients. So that's kind of where we are, and we hope to have that process done sometime this fall. Colorado is also in their affordability review process, and they have come out with findings on drugs. So I'm sure you've kind of seen those headlines in the news. But each of these boards is kind of going through this process at the same time. Next slide. So again, this is just like the technical timelines for our cost review process, and we do like to kind of provide these and make them available. And ultimately, we're hoping again to have our cost reviews done in the fall for the 6 drugs that are selected. And then just for your reference, I've included the 6 drugs that the board selected or referred to the cost review study process. Next slide. So they chose, they gave us a sequence of starting with the top 4 drugs. So Farxiga, Jardiance, Ozempic, and Trulicity. And then the next step would be to go work on Dupixent and Skyrizi. And that was because the board wants to, be careful with staff resources. Again, we're a small agency doing a lot of work. So they were able to kind of just tell us which the order of operations for the drugs that they wanted to go through the cost review study process. So we're very excited about this, this process. And, we look forward to continue to work on this and look forward to any questions that anyone has. Thank you.
Great. Thank you very much, Dr. York. I really appreciate you laying out the framework of Maryland's Prescription Drug Affordability Board, identifying your board's unique features, and providing us with that comprehensive overview of the cost review study process. I know Cap, and I'm sure many of today's attendees will be on the lookout for the upcoming RFI. So next up, I am going to turn the virtual microphone over to Shabnam Zali to share with us New Jersey's efforts to improve prescription drug affordability. Shabnam?
Great. Thanks so much, Natasha, and good to be here with you all. Great to follow Dr. York. I'm going to zoom out a little bit more to hopefully provide a comprehensive view of healthcare affordability priorities in New Jersey, and then provide a little bit more context as to how the prescription drug affordability fits into the broader set of the governor's priorities. Certainly not unique to New Jersey. Affordability, prescription drug affordability is a significant issue for our residents. But I will highlight, so if folks don't know, New Jersey is commonly referred to as the medicine chest of the world. New Jersey has something like 14 out of 20 or 21 of the world's largest drug manufacturers headquartered in New Jersey. So to give you a little bit of a sense of landscape. So, you know, I think we're significantly proud of the package that the governor signed into law just last summer, so July of 2023. And I really do think we took a very thoughtful and comprehensive approach to how we wanted to advance this work. So again, just providing some context as to how this body of work fits into the broader set of affordability priorities for Governor Murphy. There has been, you know, for anyone who's followed probably some healthcare work in New Jersey from the onset of the governor's first term. We're immensely proud of just so much work across our departments, from benefit enhancements and increases in the Medicaid department, to launch of the state-based exchange and state level subsidies in the individual market. There's so much significant work that's happened across the administration to advance affordability and accessibility to quality healthcare, but, you know, really being driven by the recognition that there is more to do, and a real need to look at affordability across markets. The governor launched in 2020 the Office of Healthcare Affordability, for which I am the inaugural director, and really we've looked at the directive for the office has been to really take a comprehensive approach and identify strategies across the areas of prescription drug costs, hospital and provider cost, and insurance premiums. So we work with agencies across the administration, and as well with an eye towards how we can potentially impact the commercial markets to identify some opportunities in this space. So next slide, please. So I'm going to touch on the HEART, or the benchmark program in New Jersey. It's one of, just really briefly before we move into the prescription drug affordability package. Again, to provide some context about the larger the larger set of work not only this office is doing, but the administration is committed to. So one of the signature programs of the Office of Healthcare Affordability is the benchmark program. Folks have probably heard of this work across a number of different states across the country. I think California being the most recent to have established their program in statute. So what the benchmark program really does, it establishes a shared goal for bringing down the rate of cost growth within the state. Specifically healthcare cost growth. We launched it through an executive order, accompanied by a stakeholder compact. Really industry stakeholders across the board agreeing to work with us in good faith to work towards the benchmarks. And what the benchmark program ultimately includes is an annual reporting to track progress in terms of performance against the benchmark targets, as well as on an annual basis, analyzing cost drivers, which includes pharmaceutical spending at the state and market levels. So the benchmark reporting both the benchmark reporting and the cost drivers analysis will consider or include reporting on a number of high spend categories, which we expect to shed additional light on how pharmaceutical cost growth is impacting and driving overall cost growth, again, across a number of different categories in the state. So if folks want to learn more about that, I'll direct you to the Rutgers Center for State Health Policy and our Department of Banking and Insurance websites for more kind of programmatic and technical information about how we're implementing that program. So moving on to the next slide. Again, focusing on prescription drug affordability, we've pursued a number of different strategies. I'll highlight a few specific to the package. Again, we recognize certainly this issue is not unique to New Jersey. Folks, so over 1/2 of residents in our state are concerned about the affordability of prescription drugs and their ability specifically to afford it. Nearly 1/4 of adults are skipping or rationing their medications due to costs. And so the package I'll highlight does a couple things. I'll talk a little bit about the comprehensive data and public reporting system we're in the process of setting up. Another bill establishes greater oversight of pharmacy benefit managers. And the third bill caps out-of-pocket costs for a lot of beneficiaries in the state, and I'll talk about some specific drugs impacted there. Next slide, please. So the first bill, and we're really excited about implementation of this. So what this does, it creates a new data and transparency system to really report on the entire, really across the drug supply chain. So includes data collection and reporting across drug manufacturers, PBMs, carriers, distributors, even a category that we did not know existed at the time, and really stakeholders raised it, called Pharmacy Services Administrative Organization. So just adding that as a nod to how complex, but also how ever advancing or really this industry is. So really comprehensive requirements across the drug supply chain. And then with that, our Division of Consumer Affairs in the Attorney General's office will work to publish annual reports based on trends, just a number of different analytics and trend reporting that they'll be doing based on the data they're collecting. There'll be opportunities for public hearings on the report findings, and then kind of, I won't go into detail now if folks, I know there's been a good amount of interest in the New Jersey transparency law specifically. I think unique to New Jersey, we have some state-specific data collection requirements in there, which I believe may be quite unique to a number of other transparency laws across the country. So if folks want more detail as to what exactly is included, certainly feel free to follow up with us or any of my colleagues in New Jersey. And the bill number is there if folks want to take a closer look at that. But our colleagues are busy implementing and really preparing for preparing for full implementation of that statute across really, developing the detailed reporting requirements and building the data infrastructure and more. And then a piece of that also is a prescription drug affordability council. So certainly different in concept from the PDAB, but allows an important opportunity to engage experts and stakeholders who will be responsible for development of a set of recommendations annually related to these issues. So moving to the next bill, this bill capped out-of-pocket costs for state-regulated health plans and our public employee health plans. It sets strict out-of-pocket caps for insulin, EpiPens, and asthma inhalers, so drugs that we know are critical for a majority of residents really across all three chronic conditions. So that I do believe New Jersey may have been the first to propose legislation that covered all three, and then I think we may not have been the first in getting that into statute, but we're certainly among the leading number of states to be able to get that in statute, and we're looking forward to full implementation of that statute shortly as well. So the third bill really establishes an oversight scheme really in a way that we haven't had before in New Jersey, requiring licensing and then a number of other kind of oversight pieces that our Department of Banking and Insurance is busy really creating and working on right now, that establishes oversight of pharmacy benefit managers. A number of different really kind of oversight licensing pieces in there, but also specific language that around certain business practices, and key piece in there is around a number of measures that we believe will help significantly prevent the practice of spread pricing. I'll kind of leave that piece there. I think one of the pieces I will highlight around this statute as well is that because of the licensure requirements at the state level, and certainly PBMs offering services and having clients across markets, we do think that there's significant potential that that this statute will be able to impact kind of how PBMs are operating and serving clients beyond just the state regulated markets. So moving on to the next slide. So I'll highlight this as well, and I'll talk really quickly about kind of how we looked at the package and the set of work we've done here. So along with the package, really over the last few years, the governor has invested and invested through the state budget, but also really had a commitment to making sure that the work that we did offered direct consumer relief to patients. So there have been significant budget investments made over the last few years and proposed for next year as well to increase eligibility and really expand benefits for tens of thousands of New Jerseyans, many of whom which are seniors and low-income individuals with disabilities. So a lot of money that we've put into premium assistance programs and prescription drug cost programs to really offer that direct relief and as quickly as possible to folks in the state who we know are just, most challenged with the cost of being able to afford the drugs they need. So kind of taking us a step back, again, kind of proud of the comprehensive approach we've taken. We've really tried to balance opportunities for direct consumer relief with things like the investments made into programs that are currently underway and have already been, kind of key features of our Department of Human Services, and including the similarly with the out-of-pocket caps in terms of providing real direct consumer relief as soon as possible for folks, while taking the time to really stand up efforts that we know are critical to transparency, to making headways on affordability in a little bit in the longer term, like the transparency laws and like the PBM oversight pieces, which we know are just going to take a little bit more time to fully implement and be able to realize some of those benefits. So it was tremendous work with stakeholders across the board, but like I said, the governor was able to sign it into law last summer, and folks are actively working towards implementation. So that's what I have on that. I'm happy to turn it over to you, back to you, Natasha, and then happy to take any questions later.
Fantastic. Thank you so much, Shabnam, for that overview of the suite of prescription drug affordability and transparency legislation that was passed. It is incredibly encouraging to see such holistic policy intervention in the medicine trust of the world. It's like, if New Jersey can do it, I feel like it is incredibly inspiring for other states that may not have the same level of opposition right in their own backyard. So next up, I am happy to turn the microphone over to Dr. Beth Slamowitz to share her experience as a part of Nevada's experience as a part of ArrayRx. So Beth, I'll turn it over to you.
Thank you so much, Natasha, and I'm excited to be here. My presentation is going to be on ArrayRx and how Nevada came to join ArrayRx. It was previously known as the Northwest Prescription Drug Consortium, and how Nevada worked towards leveraging other states to reduce drug costs for their citizens. So I'm going to kind of just go over a brief outline on the next slide and kind of let you know what points we're going to touch. So we're going to talk about initially Nevada's need and kind of how everything came about. Definitely the history of ArrayRx, why it came to be, and currently where it's at. Talk a little bit about the steering committee that exists for ArrayRx, and most importantly, what makes it different. And then lastly, really talk about the power of purchasing and partnership. Next slide. So Nevada, I want to say we're unique, but I think every state is unique in its own way. And we had a definite need for a certain population, mainly our uninsured and those individuals who had really high deductibles. High deductibles have definitely become a thing across both, private insurance. I know, especially for students, for younger people, and then also for a lot of folks that fall into our state employees program. So we recognized that there was a need to kind of fill those gaps, and knew that there was a way to leverage other states to do that. So about 2 years ago now, in September of 2022, Governor Sisolak at the time signed a directive to do a prescription discount card for the state. It was kind of our first step into the ArrayRx arena, kind of the easiest way to join the consortium. The consortium originated with Oregon and Washington and was originally called the Northwest Prescription Drug Purchasing Consortium. It may be something that others have heard. They've presented several times over the years, whether it be for different legislatures, or for the National Governors Association, for NASHP, for various other organizations. And then when they started to have other state interests and other states interested in joining, it was rebranded to ArrayRx so that it could reach a broader audience. And the process to join ArrayRx was fairly simple. It took an intergovernmental agreement. We already had statutes in place in Nevada that allowed that type of agreement to take place. So it was pretty straightforward, and we implemented in, I believe, less than a 6 months time. And currently we have just over 15,000 utilizers of the discount card, probably closer to 16,000 at this point. And the average savings for our citizens is roughly about $185 to $200 per prescription using that discount card. So the discount card is super easy. It actually has a digital sign up. The benefits to it, because often the question that I get more than anything is, how is this discount card different or better than, GoodRx or the million others, that are out there and being utilized, especially by PBMs, as well as pharmacy chains. One, there's no cost. Two, you just have to be a resident of the state. You don't have to be a US citizen, which was huge for a lot of our folks. And it is a digital sign up. So you can go online and sign up. You can do a drug search. It'll tell you which pharmacies are available, where you can pick up the medication and the different costs, so you can make the decision what's best for you. And most importantly, I think for Nevada was that it maintains sustainability for our pharmacies, because it doesn't charge fees back to the pharmacy. There isn't anything hidden. And it isn't that the pharmacy is going to lose money on each one of those transactions, as they often do with other discount cards. We heard from a lot of pharmacies, especially independents, that discount cards like GoodRx, oftentimes they wouldn't even run the discount card through. They would just charge cash price to the patient so that they didn't get charged the additional fees, which reduced their reimbursement. So that was huge. Next slide. So the biggest thing about ArrayRx is that it is created for states by states. Currently, members are Oregon, Washington, Nevada, and recently Connecticut joined through setting up a discount card. And then there are other states that we're currently working with, looking at workman's comp, discount card programs, voucher services. They currently have a fee-for-service service that they do for Medicaid. They do managed Medicaid for PBA services, rebate services. So it's pretty broad in terms of their reach of what they're able to provide to states. So it's a great resource for states when they're looking for alternatives to kind of the standard PBM and standard type of process for purchasing medications. So the consortium went out. A lot of questions that I get is kind of, a lot of people think that ArrayRx is kind of like a new thing and a new entity, but they actually went out to RFP for a pharmacy benefit administrator, and that's when they started adding services to their portfolio. And so they have you'll see it a couple slides down. They have a pharmacy benefit administrator that has experience in the industry and have worked for other states and have covered other like public employees entities and things like that. So it's not that it's something new and novel, which we get quite a bit. There's a lot of experience on this team, and there's a lot of experience within ArrayRx to manage and to assist states in all of these services that are presented on this slide. Next slide. So speaking of experience, this is our current steering committee. Each state that joins is allowed to put a member on the steering committee so that they have a voice. Currently, we have members from the Oregon Health Authority, the Oregon State Hospital Association. We have individuals from the Washington Healthcare Authority, Labor and Industries, Department of Corrections, and then with Connecticut joining, Stephanie joined, and she's with the State Comptroller Office. And so the benefit of a state joining ArrayRx is these are basically your people. Instead of needing to go out often and contract with a third party to, assist with kind of giving you best practices or, telling you what might be best or what approach to take or what policies, might work best for your state. You have that expertise built right in. These folks are at your fingertips and accessible anytime. I probably email most of them on the daily. They probably get tired of me at some point, but they're fabulous. They're all incredibly knowledgeable. They all have both clinical, state, and policy and government experience. So it's definitely a niche that ArrayRx is filling that I think a lot of states are looking for. Next slide. So the approach that ArrayRx has taken is that we're really looking to establish procurement standards. I think any state that's tried to procure with a PBM or look to purchase medications, that the standards are non-existent. They're kind of all over the place. Everybody does something differently. And I think that's where a lot of the legislation that states have kind of moved to control or to kind of rein in some of the PBMs is around the fact that we don't have a lot of procurement standards. And so ArrayRx is working really hard to kind of create those, especially for state government entities. It's important to procure contractors who demonstrate flexibility and share the values of ArrayRx. And those values include transparency as well as flexibility. Everything that ArrayRx does is transparent. All of the contracts are transparent. The pricing negotiations, everything is transparent, truly transparent. The 100% pass-through is truly 100% pass-through for the states. So we leverage an intergovernmental agreement, which I mentioned earlier. So that makes it very easy for states to join. You don't have to go out to procurement or RFP, which if any of you have done that, you know that it's quite a process. It does take a lot of state time and resources as well as cost to go out to RFP to procure a vendor. And so this is right here at your fingertips through an intergovernmental agreement. I already mentioned that, operate under complete and true transparency. And then ultimately, to govern the ArrayRx programs to ensure that the contractors are responsive to purchasing states and member organizations. And so the steering committee that you saw is really your oversight committee as well. And so you have a lot of eyes with a lot of knowledge that are overseeing the contractors that ArrayRx does have to ensure that they are meeting the standards and that they are doing their jobs in terms of all of the transparency that's expected and the standards that are expected. Next slide. So there's 3 operating principles within ArrayRx: predictability, transparency, and auditability. So we operate under a fixed PMPM fee. Basically everything, even the discount card, works under a fixed admin fee. The services are all inclusive. There's nothing that is going to be an add-on. I think, you know, having gone through a couple procurements with, you know, some of the big PBMs out there, you know, you ask for a certain clinical service, all of a sudden that becomes an add-on. You ask for, you know, a certain pricing list, that becomes an add-on. That's not the case with ArrayRx. Everything's inclusive in that admin fee. And then there are aggressive network guarantees. In terms of transparency, I've kind of already touched on this. You know, one of the big points of ArrayRx is to operate under complete program transparency. That's not something that you often get or see without forcing through legislation. And so this is kind of just the standard for ArrayRx. And then there's comprehensive reporting. Pretty much anything the state asks for, they can get. The reporting is super flexible. You have access, you know, into the PBM as well as the administrator into their systems to, you know, look up things and to create your own reporting as well if you need to. And then lastly, auditability. There is comprehensive oversight and program governance. You know, not to kind of beat a dead horse, but, you know, on the steering committee, you have all government folks, and we all know how important it is to provide oversight and accountability. And so the ability to audit, you know, those folks that we contract with or audit what's happening within the programs or services is very important. They do annual market checks. We actually just completed that. And if there is any differences, then, you know, the folks that we contract with are required to make those changes and adjustments to meet those market checks. Next slide. So a couple of things that have happened kind of recently, but are, I think, super important is just how authentic the disclosure and the openness of ArrayRx. They are backed by Arnold Ventures. We just finished a validation process with PolaraRx and doing a pricing analysis. And then at the conclusion of the evaluation that PolaraRx did, you know, this is a quote straight from them, that it was refreshing to find that ArrayRx is truly a pass-through solution, and that the transparency is apparent in both the financial aspects they provide to their clients as well as general operations. And so you can go to the ArrayRxSolutions.com website and you can read that information there if you'd like. Next slide. So as I mentioned earlier, this is the organizational structure of ArrayRx. Moda Health is the administrator that ArrayRx is contracted with. That's who they chose out of the RFP process. And so they operate under a fixed administration fee and true pass-through program processing. They manage all of the services that ArrayRx provides. And then Navitus is the pharmacy benefits administrator that operates all the PBM services, the point of sale platform, the national PBM network. There are 2 networks that ArrayRx works with. It's a narrow and a broad network. I can tell you for Nevada, we have a very rural state. And when we implemented the discount card utilizing the broad network, even our smallest rural counties, we had at least 1 pharmacy that was participating. And if we didn't have a pharmacy that was participating, Moda and Navitus were both fabulous in reaching out to the pharmacies that might exist, whether it be in that county or nearby, to ensure that everybody in our state would have had access, if they chose to the discount card. Next slide. So these are the services that are operated, as I kind of mentioned earlier, the PBM services, the discount card, voucher programs, rebate services, and then lastly, Medicaid programs. So the PBM services, they offer both Group RX, Workman's Comp, and coming soon, we'll actually have PBM services for Medicare Part D. That'll be the beginning of next year. The discount card that we've already discussed a little bit. The voucher programs for corrections, state hospitals, and county health departments. Nevada actually is currently doing some research and looking into possibly doing a voucher program with our county jails to be able to access medication-assisted treatment. And one of our local pharmacy chains that we have a couple jails because we are so rural where the closest pharmacy is about 100 miles away. And so the voucher program we're looking at might actually be a benefit to be able to get medications into those jails. The ASO rebate services, and then lastly, the two Medicaid programs, both managed and fee for service. So a pretty broad, menu of services that ArrayRx offers. Again, just to emphasize, it's by states, for states, and intergovernmental agreement. And so this is any state can join ArrayRx and benefit from all of these services and benefit from, the collective utilization and purchase power of all of those states that are involved. Next slide. So as I just mentioned, any public entity can participate. So that includes states, cities, and counties, school districts, utility districts, jails, labor unions, interlocal cooperatives, and obviously the list goes on and on. So, it's a incredible option. It continues to grow, and the amount of expertise and services that ArrayRx is, creating and developing just continues to get better. Next slide. So, again, we get a lot of questions about how the discount card is different than discount cards that are already out there. Well, we also get a lot of questions about how ArrayRx is different than other PBMs. And so you can see, that just by this list alone, which is a small list, probably not inclusive, but just the contract oversight and experience, I mentioned the steering committee being all made up of public sector employees. Leveraging negotiation power, the complete transparency, extensive audit rights, 100% pass through of all the pharmacy networks and manufacturer revenue and rebates that are collected, including specialty. There's no DIR fees, direct or indirect remunerations, no pharmacy access fees. 100% of all audit recoveries are passed through to the payer. Most favored nation contract terms, no fees to terminate the contract. We want the states to feel like, they want to be there, they're there for a reason. And obviously the ability to customize the program, because even though we're all states and we're all struggling probably with the same problems, each one of our states kind of need to approach things differently, often because of, legislation we have in place or, potentially political environment or, whatever our groups might need. The demographics of each one of our states are different. And so all of those things require flexibility. And so definitely the program wants to make sure that there's the ability for states to customize and be flexible if that's what they need. Next slide. So this is the discount card comparison. I'm not going to go into super detail here. You can go to the ArrayRx card website. You can also go to ArrayRx.com. And kind of read the differences. But this is kind of what I was mentioning in terms of ArrayRx, the discount card versus some of the other ones that are very well known. A lot of it being, that it's not harmful to the pharmacy, so that creates that sustainability while also saving money for, your individual citizens. And then, most importantly, not sharing any information, everything is private. And no membership fees, which some of the other ones will charge, whether it be at a retail chain or, one of the national cards through a PBM or otherwise. Next slide. So this is kind of just a brief overview of the savings that Nevada has seen with the discount card over time. So the Nevada discount discount card savings over 2023. The total savings was just over $1 million, over all of the lives that were touched. And again, the average savings was just about $190 to $200 per script. So it has had a significant impact for our members. Some of the research that I've done, the majority of the drugs have been, your cardiovascular diabetes drugs, and it's been generic and brand name. Obviously, there's more savings, in the brand name products, but it's nothing that's kind of been unexpected in terms of the utilization or the types of drugs or drug classes that have been utilized. Next slide. So lastly, just emphasizing, the power of partnership. I think, that's what Nevada has learned, and that's been a huge benefit of being part of ArrayRx, is that there is always power in partnership, whether that be through, group purchasing and negotiating rates, aggregating group members to reach lower thresholds, or, aggregating claims volume to reach lower fees. Big one's been the RFP cost and resources. I think both of the other speakers have mentioned, state resources. We all know how stretched thin we all are. And so, being able to utilize resources that other states do have and work collaboratively has been huge. We have 2 meetings per year where the steering committee gets together along with members of Moda Health and Navitus. And we talk about what worked, what didn't work, goals for the future, how we can, address other states' issues. So it's been really great to collaborate with everybody on that steering committee and other states. And it kind of just makes you feel less alone. So the contract services and rates negotiated, again, that's all collective. And then even, the templates for the program and things like that, that we create and customize, to create some standards across states, has been hugely helpful as well. So I'm going to stop there and throw it back to Natasha and answer questions when we're all ready to wrap up.
Fantastic. Thank you very much, Dr. Slamowitz. I enjoyed learning about ArrayRx and the breadth of the programs you offer, as well as the upcoming expansion. It truly is a strong 4 states by state solution. So I would like to actually invite all of our panelists back to the virtual stage for a brief question and answer. We have some great questions in the chat from today's attendees, and I will go ahead and compose the first one. So there have been some inquiries around the levels of resistance that you have received from the pharmaceutical industry as your respective states have pursued pricing and transparency reforms. And if you wanted to share how you were able to navigate those areas of opposition and any best practices that you might want to share with folks in the audience.
I'm happy to start. This is Andy from the Maryland Prescription Drug Affordability Board. So I saw the question, and I would say that you see the general kind of expected opposition and policy perspectives as you would expect from each of the different stakeholder groups. But in our experiences so far, we found all the stakeholders, including manufacturers, to be very, strong and willing partners. I think there's a general agreement that patients should be able to afford and access their drugs, and as long as we're all kind of working towards that purpose, I think we can try to find, certain issues where we're on the same page. And then one other thing, there are certain policies that different stakeholders will have different perspectives on. And our board has had to, try to say that we're looking at basically all the solutions that are on the table to make prescription drugs more affordable for our residents. And I think that's allowed some of these conversations to continue. So just because we find that a patient can't afford their drug or it's a high cost of the healthcare system, that there's a number of policies that you can try to use to try to address that issue. So,
Natasha, to your question, I'll add. So probably in my presentation, folks heard me say, kind of a comprehensive approach, probably one too many times. So, I think we were very thoughtful in not kind of doing these one-off bills related to prescription drug costs. We wanted to, I think we understood that there is no one part of the supply chain, or there is no one part of the industry that is any more responsible than any other, or that I think there was an understanding that there is essentially a lack of transparency and probably a lack of understanding, especially kind of amongst policymakers, in terms of kind of what is happening all across the supply chain and how that impacts pricing. So it was really important to us that we were taking just a comprehensive and holistic approach, which I think very much helped in our conversations with industry, saying, listen, there isn't any one single bad guy here. That is not what we're looking for and not what we're looking to do. We need to build transparency in order to ever be able to build accountability here. And that's us fully understanding and having access to data in terms of what's happening. So I think industry appreciated that approach, and it made the legislative process certainly very challenging when you need to have discussions with all of these different entities and all of these different parts of industry. But I think a lot of folks appreciated that approach, as difficult as it was, that we were doing our best to just to fully appreciate how complicated and how sophisticated that supply chain is.
I don't have a lot to add, I guess, in terms of, transparency other than what's already been said. I can say, from the ArrayRx approach, one of the benefits has been that, it's almost allowing multiple states to be able to negotiate directly with the manufacturers and kind of eliminating some of the pieces of the supply chain that might add additional, perhaps, fees or cost, things like that. Also having, the knowledge of the other states. Washington was one of the states that was mentioned that has a drug affordability board. They're part of ArrayRx, so they have a ton of knowledge around those things. So I think from that perspective, Nevada's had their own kind of issues when we implemented our transparency laws and work in terms of trade secrets and what the manufacturers, I think, pushed back on. And we had to put some regulations in place in terms of kind of allowing them to dictate what is a trade secret. But in terms of negotiating and purchasing power, I think that, when the states collectively get together and you have utilization that's being aggregated, it's actually a benefit being able to work directly and have that transparency with the manufacturers.
Great. And I think for our final question, there were some inquiries around kind of the relationship between the federal efforts and state efforts. So as we conclude, I would just pose to you, can you discuss kind of the impact of federal policy on your state's efforts around prescription drug affordability reform, and what, if any, additional federal support would be helpful?
Way to take a first pass. So there's definitely a clear delineation between kind of like what's regulated by the state and what's regulated at the federal level. And our sandbox is basically what we can do at that state level. Though I do think there is a lot of coordination, especially for programs that do go across state and federal lines. So like Medicaid, for example, I think we work pretty closely with the federal government. Centers for Medicare and Medicaid Services obviously, houses the biggest payers in the United States, and what CMS does often sets the market. So we are kind of like watching what they do. They also have their innovation center where they test out different policies. So, I'd hope that it is the same for us, where states are able to test new and interesting policies, and then hopefully our federal partners can kind of learn from our experiences as well. So we're learning from the feds, and then also hoping that they can learn from us as well.
So I'll quickly add. I'm not sure if this will answer your question specifically, Natasha, but I'll add. I think there being policy alignment at the federal administration with what states are looking to do is a significant boost, right? To, I think, just building that momentum, building that excitement amongst stakeholders to be able to advance state level policymaking as well. And whether if you can show how it's complementary, if you can show that you're either building upon or kind of potentially even kind of going farther. Like I think it builds the landscape and helps boost, I think, the landscape and the level of discussion in a way that is really then helpful to move things in terms of policy making. I will say, like, there is also so much happening through the IRA and through a lot of just the regulations or in terms of all the data collection that the feds are doing. I certainly have not, and not sure if everyone kind of has fully appreciated what that will mean in terms of the data and how much light that'll shed for us at the state level in terms of what's happening at our kind of at the state level. So I think we're really excited to be able to learn from that and really understand how it can be complementary to our efforts as well.
Yeah, and I'll just wrap up by adding that, I think some of the movement at the federal level to have, conversations with some of the largest PBMs and kind of try to, dig into what's happening and the transparency, I think is just shining an even bigger light on why, things like ArrayRx are needed, why, states need to continue to fill those gaps and need to look for their own standards and ways to create that transparency and provide the best services, for the members of their states and abroad. So, you have to remain flexible. You have to keep moving. Pharmacy is a world where nothing stops ever. It's constantly moving in real time. So I think that, we're all going to have to just continue to find how we can fill those gaps and how we can create policy and services to provide, the best affordability to the members of our states.
Well, we are at time. So Andy, Shabnam, Beth, thank you so much for sharing your insights and expertise today. Thank you to our audience for joining us. And I encourage everyone to save the date for the next installment in the speaker series, which is going to be Thursday, July 18th, where we'll be focusing on policy to avert and alleviate medical debt. So thanks for joining, everyone, and we'll connect soon. Bye.